Welcome to the deep dive. Today we're getting into hereditary angioedema, or H.A.E. Now, we know medical topics can sometimes feel a bit, well, dense, but our aim here is really to pull out the crucial bits, the things that you need to remember to give you a really clear understanding for revision.
Exactly. We've got a solid set of notes here covering HAE, what it is, the causes, symptoms, how it's diagnosed, and importantly, how it's managed.
Right.
So our mission really is to boil this down into that high-yield information you need, maybe with a few memory aids thrown in.
Perfect. Right then, let's dive straight in. Hereditary angioedema, what's the headline? What actually is it?
So basically, HAE is a rare genetic condition, something you're born with. The big thing, the key characteristic, is these recurrent episodes of swelling.
Okay, swelling, but different from normal swelling.
Yes, quite different. It's typically non-pitting, so if you press on it, it doesn't leave an indent, and crucially, it's not itchy, non-pruritic.
Non-pitting, non-itchy swelling. Got it. What's actually causing this to happen? What's the mechanism?
Well, the root cause is a deficiency, or sometimes a dysfunction, of a protein called C1 esterase inhibitor. We usually just call it C1-INH.
C1-INH, okay.
Yeah, and the C1-INH normally acts like a brake on part of the immune system, the complement system. Without enough working C1-INH, that system goes a bit haywire. It gets overactive.
And that leads to?
That leads to an excessive release of a substance called bradykinin.
Ah, bradykinin. I feel like that's the key player here, the troublemaker.
You've got it. Bradykinin is really central to HAE. It increases the permeability of your blood vessels. Makes them leakier, essentially.
Leaky vessels. So fluid escapes.
Exactly. Fluid escapes into the surrounding tissues, and that's what causes the localized swelling you see in an HAE attack.
So the C1-INH brake is faulty, and the bradykinin tap is just wide open. Is there an easy way to remember that link?
Yeah, there's a nice little mnemonic. Think of the letters H.E. You could think of it as hardly any enzyme, meaning the C1-INH.
Hardly any enzyme.
And the consequence of hardly any enzyme, huge amounts of edema, the swelling.
Hardly any enzyme, huge amounts of edema. Love it. That's definitely helpful. So where does this enzyme problem actually come from, the root cause?
It's genetic. It comes down to mutations in a specific gene called SERPING1.
SERPING1.
Yeah. You can maybe think of SERPING like a serpent, a snake, causing trouble in the gene, messing up the instructions for making that C1-INH protein.
Okay, a sneaky SERPING gene. And how is it passed down?
It's typically autosomal dominant,
Meaning
you only need to inherit one faulty copy of the gene from one parent to potentially develop the condition.
Right.
Although it's worth saying, sometimes these mutations can just happen spontaneously. So not everyone with HAE will have a family history.
Okay. And this bradykinin, where does it cause the swelling? Which parts of the body?
It can affect quite a few areas, commonly the skin, the mucosa, so the lining of the mouth, the gut, the gastrointestinal tract, and really importantly, the upper airway. Swelling there is critical.
Airway swelling sounds serious.
It is, potentially life-threatening.
You mentioned types earlier. Are there different forms of HAE?
Yes, the two main ones are type I and type 2.
What's the difference?
In type I, the problem is low levels of the C1-INH protein, just not enough of it being made. So you could think one is low.
One is low, okay.
In type 2, the level of protein might actually be normal or even high, but it doesn't function correctly, it doesn't do its job.
Yeah.
So 2 doesn't do.
One is low, 2 doesn't do.
Got it. Simple ways to remember. So who's most at risk then? Is it just genetics?
Pretty much. The primary risk factor, overwhelmingly, is having a family history of HAE. If it runs in the family, the risk is obviously much higher.
Makes sense. So we know what it is, the genetics. Can we talk a bit more about the pathophysiology? How exactly does the faulty gene lead to this swelling attack?
Sure. So it's about dysregulation. The contact system and the complement system, these are parts of our innate immunity, right? They normally help fight infection, control inflammation.
Fine. The body's defenses. Exactly. But in HAE, without enough functional C1-INH acting as that brake, these systems become, well, unbalanced, overactive.
Like the alarm keeps ringing.
Precisely. The contact system gets triggered, which then activates other pathways, leading ultimately to this excessive production of bradykinin. And as we said, bradykinin is the key mediator.
And the bradykinin then does what to the blood vessels?
It causes vasodilation, the vessels widen, and crucially, it increases vascular permeability, makes them leaky.
So fluid leaks out.
Fluid leaks out into the tissues, causing that localized swelling, the angioedema, and inflammation that characterizes an attack.
Okay, that paints a clear picture. Now, this type of swelling sounds quite specific. Are there other conditions that look similar? What else might be on the differential diagnosis?
Yeah, that's really important because angioedema itself isn't unique to HAE. You absolutely have to distinguish it. The most common confusion is probably with allergic angioedema.
How do you tell them apart?
The big clue for allergic reactions is usually itching pruritus and often hives, which we call urticaria. HAE swelling is typically not itchy and happens without urticaria.
No itching, no hives. That's a key differentiator. What else?
Well, there's also acquired angioedema, which isn't genetic and usually starts later in life. Then there's idiopathic angioedema, meaning we don't know the cause. And a really important one to ask about is ACE inhibitor-induced angioedema.
Ah, drug side effect.
Exactly. Certain blood pressure medications, ACE inhibitors, are well-known triggers. So a good medication history is vital.
Good point. Always check the meds. So thinking about HAE itself, how common is it actually? What's the epidemiology?
It's definitely considered rare. Estimates vary, but worldwide, prevalence is thought to be somewhere between, say, 1 in 10,000 and 1 in 50,000 people.
And in the UK?
Specific UK data is a bit limited, but the incidence is generally quoted around 1 in 50,000. So, yeah, not common.
Does it affect certain groups more?
No, it seems to affect all ethnic groups and both sexes pretty equally. And as we mentioned, it often first shows up in childhood. Usually around 8 to 12 years old is typical for onset.
Okay, rare, genetic, often starts in childhood. Let's talk about the clinical features. What does an attack actually look like? What should make you suspect HAE?
The core feature is those recurrent episodes of angioedema, often starting in childhood, sometimes getting worse around puberty. Family history is obviously a big clue, but remember those spontaneous mutations mean it's not always there.
And the swelling itself, what are the characteristics?
Well, as we've stressed, the most critical manifestation is laryngeal edema, that swelling in the throat. It can be life-threatening, so it needs immediate attention.
Okay, airway is top priority. What about other areas?
You also get subcutaneous swelling under the skin, typically localized, non-pitting, and remember, without urticaria, no hives.
And you mentioned abdominal issues.
Yes, abdominal attacks are very common. They can cause severe pain, vomiting, diarrhea, sometimes mimicking things like appendicitis or bowel obstruction. It can be a real diagnostic challenge.
How do the attacks behave? Are they sudden, long-lasting?
They usually develop over several hours, maybe 12 to 36 hours to peak, and then they typically last for about 2 to 5 days before gradually resolving. The frequencies are really variable, though some people have attacks weekly, others might go months or years between them. Very unpredictable.
Are there known triggers, things that set off an attack?
Yes, although they can differ between individuals. Common ones include minor trauma or injury, infections like colds or dental infections, stress is a big one, medical or dental procedures.
And medications.
Definitely. Estrogen-containing medications like some birth control pills or HRT and ACE inhibitors are known triggers that people with HAE should usually avoid.
What about pregnancy?
It's variable. Some women find their attacks get better during pregnancy, others find they get worse. Needs careful management.
Any other little signs?
Some patients, maybe about a third, describe a prodromal rash before an attack. It's often described as a non-itchy, sometimes slightly tingling, flat, discolored rash called erythema marginatum. But the swelling itself, in the skin and mucosa, is typically painless and non-itchy.
Okay, so summing up the features, maybe think of the A's in angioedema, affects the airway, the abdomen, and the appearance, meaning the skin.
That's a great way to think about it. Airway, abdomen, appearance, and always remember, no itching, no pitting, no hives.
Perfect. So if you suspect HAE based on these features, how do you confirm the diagnosis? What investigations do you do?
There are some key diagnostic pointers we look for. That family history, the recurrent non-itchy swelling lasting more than 24 hours, any history of throat swelling, those unexplained severe tummy pains, onset in childhood, worsening in adolescence, and the lack of hives. If those flags are there, you move to blood tests.
What are the key blood tests?
The crucial initial tests are serum C4 level. This is usually low during an attack and often low even between attacks in most types of HAE.
Okay, C4 first.
Then you measure the C1 inhibitor itself. 2 tests here. Right. The C1-INH antigenic level, which measures the amount of protein, and the C1-INH functional level, which measures how well it works.
Amount and function. Got it. Genetic tests.
Genetic testing for the serpiginous gene mutation can be helpful, especially if the blood tests are borderline or if you need confirmation, but it's often the C4 and C1-INH tests that give you the diagnosis.
How do you piece those results together then? Low C4 mean?
So if the C4 level is low and the C1-INH level, amount, and function are both low, that usually points strongly towards HAE type 1. especially with a family history.
Okay, type 1 is low everything. What if C4 is low but C1-INH level is normal?
If C4 is low, but the C1-INH level is normal or even high, that's when you absolutely must look at the C1-INH function. If the function is low, that suggests H.A.E. type 2. The protein is there, it just doesn't work. 2 doesn't do.
Right, makes sense. And if C4 is normal?
If C4 is normal and C1-INH levels in function are normal, H.A.E. type 1 or 2 is less likely. You might need to repeat the tests during an actual swelling attack, as C4 can sometimes normalize between episodes. Or you think about other causes like drug-induced angioedema or rarer H.A.E. types with normal C1-INH.
That's a really clear diagnostic pathway. Are there any other general tests done once H.A.E. is confirmed?
Yeah, usually some baseline checks are done, things like a full blood count, liver and kidney function, maybe lipids, checks for bloodborne viruses if they might need plasma-derived treatments down the line, urinalysis, just general health screening, really.
Okay, so we've got the diagnosis. How do we manage H.A.E.? What's the treatment approach?
Right. The absolute first thing to hammer home is that standard allergy treatments, adrenaline, antihistamines, steroids, they generally do not work for H.A.E. attacks.
That's crucial. So what does work for an acute attack?
For an acute attack, especially if it's affecting the airway or is severe, the mainstays are specific H.A.E. therapies. First line is often intravenous C1 inhibitor concentrate, basically replacing what's missing or not working.
Giving back the C1-INH.
Exactly. Options include plasma-derived ones like Berinert or Cinryze, or a recombinant one called Ruconest. Another option is fresh frozen plasma, FFP, which contains C1-INH, but the concentrate is usually preferred as it's more specific and safer.
Any other acute treatments?
Yes, there's also a Kedavant, brand name Firazyr. It's different. It's a bradykinin receptor antagonist. It blocks bradykinin from acting on the blood vessels, given as a subcutaneous injection.
So replace the inhibitor or block the bradykinin. What about overall management, day to day?
It's multifaceted. Key principles are ensuring rapid access to that acute emergency treatment. Patient education is vital, recognizing attacks early, knowing triggers, maybe even learning self-administration of treatments like a Kedavant or C1-INH.
Prophylaxis, too, preventing attacks.
Yes, prophylaxis is really important. There's short-term prophylaxis used before procedures that might trigger an attack and long-term prophylaxis to reduce the overall frequency and severity of attacks for those who have them often.
And testing family members.
Absolutely recommended, given the genetic basis. And historically, immunization against Hep B and A was advised for those using plasma products, though the risk with modern concentrates is very low.
You mentioned some drug names, Berinert, Cinryze, Kedavant. Any others used?
Ecallantide is another drug that inhibits kallikrein, an enzyme involved in bradykinin production, but it's not widely available in the UK and carries an anaphylaxis risk.
Yeah.
Older options for long-term prophylaxis include attenuated androgens like danazol.
Danazol. Sounds hormonal.
It is. It can be effective, but comes with a significant side effect profile, especially virilizing effects, so it needs careful consideration and monitoring. Tranexamic acid, an antifibrinolytic, is sometimes used, but the evidence for its effectiveness in H.A.E. is weaker.
Okay. How does treatment differ depending on where the swelling is during an attack?
Good question. Laryngeal edema throat swelling is an absolute emergency. Immediate C1-INH or a Kedavant, no delay. Facial or neck swelling is treated as potentially compromising the airway, so treat promptly too. Severe abdominal pain usually gets C1-INH or a Kedavant. Peripheral swelling, like in an arm or leg, might be managed more conservatively with watch and wait if it's mild, or acute meds if it's severe or impacting function.
What about that short-term prophylaxis for procedures?
Essential for things like surgery, dental work, even endoscopy. Usually give a dose of C1-INH concentrate close to the time of the procedure and have another dose ready just in case. FFP is a second-line option, and you maintain high vigilance for any airway issues.
And long-term prevention, beyond avoiding triggers.
Focuses on reducing triggers, good dental care, treating infections quickly, avoiding those trigger meds like estrogens and ACE inhibitors. Medication-wise, regular infusions of plasma-derived C1-INH Cinryze is an option, or androgens like danazol with the caveats we mentioned. Regular specialist review is key to tailor the plan.
Is there anything newer for long-term prevention?
Yes, there's Berotalstat. It's an oral daily medication. It's a plasma kallikrein inhibitor, so it works by reducing bradykinin production. NICE is recommended for certain patients with recurrent attacks.
That sounds promising. What about specific groups like pregnant women or kids?
Pregnancy needs specialist input. Test results can be harder to interpret. C1-INH concentrate is the preferred treatment for acute attacks and for prophylaxis during pregnancy. Androgens are generally a no-go. Labor and delivery need careful planning with C1-INH on standby.
And children.
Plasma-derived C1-INH is approved for acute treatment and prophylaxis in children. Trials are ongoing or completed for recombinant C1-INH and icatibant in kids. For long-term prophylaxis, antifibrinolytics like tranexamic acid are often preferred over androgens. And obviously, education for the child, family, and school is crucial.
It sounds like a complex condition to live with. What's the overall prognosis, and what are the main complications to worry about?
It is a lifelong condition, absolutely. But, and this is the important bit, with effective management, people can live full, relatively normal lives. The major, most feared complication is, without doubt, death from asphyxiation due to untreated laryngeal edema.
That really underscores the need for prompt treatment.
It does. And it can happen even with a first attack, and tragically, it does still happen occasionally. Knowing there's a family history of deaths from swelling can also have a huge psychological impact.
Are there other complications?
Well, that severe abdominal pain can lead to misdiagnosis and unnecessary surgeries if H.A.E. isn't considered. Side effects from long-term androgen therapy, like danazol, can be an issue. The risk of bloodborne infections from treatments is thankfully very low now with modern processing. But overall, if it's not well controlled, the unpredictability really impacts quality of life, work, school, social life.
Are there new treatments on the horizon giving more hope?
Yes, definitely. Research is very active. We mentioned ecallantide, approved in the U.S. And lanadelumab, it's another monoclonal antibody, a kallikrein inhibitor given by injection every few weeks, which has shown really excellent results in trials for preventing attacks. It's becoming more widely available. So the treatment landscape is certainly improving.
This has been incredibly informative, a really thorough look at H.A.E. Just to quickly summarize the absolute key take-homes for revision.
Okay, key points. H.A.E., rare genetic C1-INH deficiency or dysfunction, leads to excess bradykinin, causes recurrent swelling, angioedema. Remember, non-pitting, non-itchy, no hives, urticaria.
And the big danger zone?
Laryngeal edema. Airway obstruction risk. Abdominal attacks also common and severe. Diagnosis relies on C4, C1-INH level, and C1-INH function tests.
Treatment.
Acute attacks need specific therapies like C1-INH concentrate or icatibant. Standard allergy meds don't work. Prophylaxis is important for many.
And distinguishing it from allergies is key look for that lack of itching and hives.
Exactly. Clinical suspicion, family history, and those specific blood tests are crucial for diagnosis and getting people onto the right management plan.
Fantastic. If you listening have found this deep dive useful for your MSRA revision and you're looking for more resources, practice questions, mock exams, basically everything to help you ace it, definitely head over to passthemso.com.
And we also have a load of great free learning materials, notes, and tips available as well. You can find those at freemsra.com.
It really is encouraging to see how understanding and treatment for rare conditions like H.A.E. have advanced. It's a testament to research and gives real hope. Thanks so much for joining us for this deep dive.